The title of Dr. Cruz's talk today is U.S. Healthcare Systems, Time for International Comparative Policy Analysis, and that probably couldn't be more timely. Dr. Cruz has been an active advocate for healthcare policy in the United States through a range of organizations such as the Society of Teachers of Family Medicine and on the Council of Graduate Medical Education, through which he has advised past secretaries of the U.S. Department of Health and Human Services. But he also brings an international perspective to this, having served on the ground providing medical care in the country of Honduras. Dr. Cruz has a special interest in cross-cultural and population health to inform effective policies and to improve healthcare systems. So please join me in welcoming Dr. Cruz to address these issues for us.
Thanks so much, Hillary. Thank you very much. Well, it's a pleasure to be here tonight. I'll just say this is a great new facility, the Student Union here, and congratulations to everyone at UIS for that. Susan, thanks so much, and Hillary for the introduction. It is a pleasure to do things in partnership with UIS. So SIU, UIS, UIS, SIU, there's a certain symmetry there, I think, as a matter of fact. We'll just leave ISU out of this for right now, as a matter of fact. So, I'll just say that I think all of you know that there are pockets of excellence in healthcare in the United States. But I think virtually all of us have felt that at times the care is fragmented, sometimes incomplete, and certainly, compared to the rest of the industrialized world, somewhat inaccessible. Therefore, our healthcare, population-based healthcare outcomes do tend to pale in comparison to other industrialized nations, and we spend a lot of money on healthcare, as a matter of fact. So other countries have done it better than we have on that population basis, and they've done it in a variety of different ways that have fit their country, and they have some similarities to the U.S. And so tonight, international comparative policy analysis is actually a discipline in and of itself. You can look that up, as a matter of fact. But in essence, it's taking the best from other groups of people or other nations and applying that in ways that's useful to the United States. Now, the United States has been loath to do that at the political level. I was just informed that Donald Berwick, who was the head of the Center for Medicare and Medicaid Studies for years, well, just for 2 years actually, always said, don't mention the healthcare system of any other country when you're trying to get something done in Washington. I think it has something to do with the ideas of American exceptionalism and some of those other things that we really need to put aside to some degree. So anyway, that's an unknown. Does anybody know what that is? Hurricane. Now, Hillary said something already. Which hurricane is that? What? It's the one that hit Honduras, as a matter of fact. That is Hurricane Mitch, and that's 1998. Hurricane Mitch arose in the Caribbean Sea on October 22nd, went to the north coast of Honduras, stalled, became a Category 5 hurricane with sustained winds of 180 miles an hour, completely destroyed the rainforest and the banana groves on the northern end of Honduras, moved inland, and for 2 days moved across Honduras, dropping 2 years' worth of rain in 2 days, and really destroyed Honduras. I mean, actually, that's a picture of how big it is. It was the second most deadly hurricane in history, and you can see it reaches all the way from Cuba there to Honduras. And there's the map. It starts in the Caribbean, comes up to the northern coast of Honduras, Category 5, makes landfall, Category 5, goes through Honduras, veers to the west, about a Category 2 by this time, goes across the Yucatan Peninsula, out into the Gulf of Mexico. At this point, it gains strength again, becomes a tropical storm, hits Naples, Florida on November the 5th. That was a late hurricane, as a matter of fact. But this is what happened. Honduras is about the size of Tennessee. It has 110 bridges, and 109 of them were destroyed by Hurricane Mitch. Now think about that. Think about all the bridges in a state being destroyed except one. That's a devastation. The southern part of Honduras looks like New Mexico and Arizona. And there were a lot of mudslides down the mountain. Obviously, that's where most of the houses were, so the devastation there was great as well. But one thing that happened was the brave mothers and fathers of the children in Honduras actually tried to save their families, and for many families, both the mother and father were killed, and so many orphans resulted from that, and they were called Mitch kids. So I had the honor, actually, of 6 times going to Honduras to do public health and provide primary care in the rural areas in the southern part of Honduras that was devastated by Hurricane Mitch. And fortunately, some other organizations started looking at the public health needs and trying to rebuild the public health in Honduras. So one place that we visited frequently was Pedro Atala Orphanage in Tegucigalpa. Our headquarters was in Nuevo Paraíso, which was very near Tegucigalpa and near the Nicaraguan border there. Everything needs a champion. So Sister Maria Rosa Legal, also called the Mother Teresa of Central America, was trained as a nurse in the 1940s and 50s in Honduras and Milwaukee, Wisconsin, and she took it upon herself to improve the health care in Honduras. She established those orphanages and organized the medical brigades that came and tried to help things out. The brigade that I went with was called Global Medical Brigades. I went with Marquette University. They are student-led, and most of them are undergraduate students. A few of them are professional students, and a handful of healthcare professionals, mostly physicians, go as well. After I went those times with Marquette University, the SIU School of medical students, they took this cause up, and they've gone a number of times, and that's the story for today. The first time we were there, we went to a small village, which was very difficult to get to, called Potrero Grande. And Sister Maria Rosa, at that time, was instituting a new policy. Previously, she had the orphanages and the public health policies that were separate from the brigades that went to the small towns in the mountains. This time, she was linking public health to the brigades. So she had sent a group of people from Sociedad Amigos de los Niños, her organization, to go set the stage there and get community leaders thinking about what they could do to keep the healthcare going. So as we arrived that morning at the inaugural visit of the new public health policy, just like this is the inaugural night and dinner here at the Student Union, Sister Maria came in the bus and sat down among us to encourage us and just tell us what the program was. So we had some comments, and I made a few comments, and she says, "He understands what's going on. Let's give him the clap." Oh, yes, your clap. I said, no, that actually happened, as a matter of fact. So she articulated the public health imperative. Actually, it was pretty impressive, to tell you the truth. Anyway, this is the office. We were all in the same room. We had an interpreter. A young man from the village named Jaime actually hung around me. I'm in the Marquette jersey right in the middle with the gold lettering there. And we gave some pretty good care that day. I did tell Jaime at one of the breaks, and he spoke just a little bit of English, that I had never seen ears that were worse than those in Potrero Grande. Glue ears, chronic infections. The children had difficulty hearing. Fortunately, we'd packed a lot of azithromycin that we could give for a few months, and we really wished we could do a tympanocentesis to let off that fluid. Anyway, what happened at the end of the day, before it got dark, was Sister Maria Rosa had actually arranged for the leaders of the brigade and Dr. Sanchez, who's in the white hat, to address the leaders from Potrero Grande to make sure that they understand what the public health imperative was. And the public health imperative was this: either you do these things or we're never coming back, because we can spend our time in another place. So they were talking to the leaders of the community, and so Sonia, in the red with the microphone, was the president of the community, and Jaime is sitting beside her to her left in the blue shirt. So as the leaders responded, actually there was a little bit of shying away by Sonia, Sanchez said, we need a commitment right now, and your attitude won't do. That's exactly right. So Jaime at that time, and I didn't get a photo of this, stood up and said, I have fire, I have desire, I want to be the community leader. So he agreed to be the one that would chlorinate the water, that would learn to use the two-way radio, that would go to Tegucigalpa to pick up the vaccines, and would learn some basic urgent care skills and some other things. So he was very positive about that. Actually, here's an interesting sidelight. At that time, Honduras, the second poorest country in North America, had an effective immunization rate at age 2 years that was higher than the United States, amazingly enough. Anyway, we came back the next year, and Jaime ran to the bus, and he'd given me a nickname the first year, Geraldo, so he was yelling, Geraldo, Geraldo, and he had a little notepad, and he was very excited. So he told me that he really couldn't chlorinate the water supply, but he could chlorinate an individual barrel of water, and he had tracked the number of diarrheal illnesses on the graph. He said, I'll bet that the ear infections are better because swelling of the glands will be less. Really, that's amazing stuff. Sure enough, and this is a very good study, actually. I didn't see nearly as many glue ears that year. But guess how old Jaime is right in the picture? 19. He was 18 the year before. And so the next year we came back, where's Jaime? He's in Tegucigalpa training the community health workers. So that was my first step into the training of community health workers and the effect that they could have. Really, the improvement in health in the community over 2 years and the community members stepping up to take care of themselves was really heartwarming. It was really good, as a matter of fact. Now, we'll move forward to SIU for a few minutes. As I said, a bunch of the medical students for some years have been going to this program. Also, some faculty members have as well, and so we've done a variety of community outreach projects. I just mentioned this one quickly, our Enos Park project, that was a 2-year project whose basis was the training of community health workers. So our students were really engaged in this. 40 of them became trained as community health workers. Over 100 people from the community who lived in the community became trained as community workers. The SIU School of Medicine, Memorial Medical Center, St. John's Hospital, and the Sangamon County Health Department sponsored the entire program, engaged the other communities, the other organizations in the community and do with it. Yeah. Hello? There we go. Okay. To get this project going. I'll just say that those community health workers did some amazing things. I can give you a lot more about this, but this effort was led by Tracy Smith of the Department of Community Medicine. She's a doctor of nursing practice, a DNP. And the area that was engaged was a 36 square block area with a population of 2,500 people. The outcomes that have just been measured are astounding. You can see them there. Much more engagement with medical care. 87% of the homeless became housed. Employment, total income up significantly. Police calls decreased, and all kinds of health indicators better. A tremendous success story, actually, that was probably by the inspiration that occurred when the SIU students went to Honduras. So that's a good one. Okay, so now I'm going to do a few international comparisons. I don't want to bore you with these things, but they do tend to be important. So demographics are important when we think about the issues that our country and other countries have. This graph is a graph of the ratio of people in the workforce who are earning money and paying Medicare tax. That's the numerator. And the denominator is the number of people on Medicare who are receiving Medicare benefits. As you see, for some number of years, that ratio was about 4 to 1. And as you see, by the year 2040, it's going to be about 2 to 1. But what that means is over a period of time, we're going to have a rapid drop in that ratio, and that means that we have to change the way we look at healthcare in the United States. So there's a 35% decline from 2010 to 2030. We're right in the midst of that right now, and we'll have to come up with some solutions. From the international perspective, there are countries that are worse off than we are. Japan's ratio is going to drop from 6 to 1.5. And that's a very difficult problem that they're going to have over the next 20 years for sure. But we'll think about ours for the moment. The other thing is, when we talk about population-based healthcare outcomes, since the 1980s, there's been a gap between the United States and the rest of the world, but in the 1980s it was relatively small, and it grew over a period of time. When we hit the year 2000, from 2000 to 2008, that gap between the United States and the rest of the world actually widened significantly. We got worse. Then things have kind of leveled off in the gap for a period of time. But these are the areas where we have problems. Spending, access, our access has improved a little bit. We'll talk about that in a moment. Quality indicators, and then especially I wanted to just mention that the United States has a special significant problem with the care of women of childbearing age and children. Certainly, compared to the rest of the world's population-based healthcare outcomes, the worst the worst segment in our performance, actually. And then that's been accompanied by a dramatic decline in choice of health professional students for care careers. And the percentage of medical students choosing primary care, the percentage of physician assistant students and nursing students, nurse practitioner students choosing primary care careers has gone down in parallel. Okay, so here's healthcare spending. This is in purchasing power parity, which is the best way to compare various countries. This is US dollars purchasing power parity, a study that's continually done by the University of London and is published by the Organization for Economic Cooperation and Development, the OECD. The OECD has 34 member nations, which are basically the richest, most industrialized nations in the world. So as you see here, the United States in the red spends significantly more. It only goes through 2004 there, but the 2016 data came out last week for OECD. I think most of you know that in 2017 we topped 10,000. That headline was out, but the rest of the world's data is not there yet. In second place, well, they're actually Switzerland is in second place, but it's not on the graph. Of large countries, in second place is Germany, a very technologically advanced country that we'll talk about a little bit more in a moment, and the United Kingdom. You see the major gap there. You see the black arrow, that's the year 2000, and if you take a look at the slope of the red line, there was a significant uptick there. Those 2000 to 2008 are really pretty much the dark years in some of the things that went on in American medicine. Okay, you've probably heard about you've seen graphs of the percentage of U.S. gross domestic product that's part of healthcare expenditures. And this is how things have gone. It was about 5% in 1960, pretty much a linear increase until 1990, and pretty much an inexorable increase. Now, when I was on the Council on Graduate Medical Education for the Department of Health and Human Services, we had all kinds of experts that came and spoke to us. The Government Accountability Office, the Medicare Advisory Commission, the Central Intelligence Agency. And what they were worried about was that the United States was going to spend too much on health care. And they thought the magic number was 20%. All of those organizations. We were instructed that if the percent of GDP spent on health care went over 20%, we would not have enough to really have effective systems to compete with the rest of the world in education, transportation, defense, social services, and those things. You might note here that there are two flattening periods, and those are basically between 1992 and 2000, and then from 2008 to 2016. You might ask yourself, why is that? We might get to that in a bit. But actually, kind of pulling that graph apart, this is what you see. Again, pretty much a continued rise, but at some period of time, the United States did tend to figure out healthcare spending. Now, most of you have probably heard on the news for the past couple of years that healthcare costs are rising dramatically, right? Well, guess what? Take a look from 2009 to 2016. As a percentage of GDP, which actually was growing at about 2%, so it wasn't growing very fast, that was flat. So the cost and the spending on healthcare did not rise rapidly during that period of time. There was just more that was coming out of your pocket. And that has to do with a lot of things that some of this comparative analysis will help. Now, okay, let's talk about quality for a minute. Now, the medical students, they do standardized tests that have a mean of 500 and a standard deviation of 100. And so they get those and they know if they're going to be likely to pass their board exams when they're done. And so for the United States, let's give a report card, right? All right, so we broke the United States down into three groups: people over age 65, women of childbearing age and children, and everybody else. Any ideas of what you'd predict for the scorecard there? Which one do we do the best in? Who thinks we do the best for the elderly? How about two, everyone else? How about women and children? No, nobody's voting very much here tonight, as a matter of fact. Anyway, so in some relatively small but rigorous analyses that are done, the health care that senior citizens in the United States gets actually stacks up pretty well. It's above the median. But for the other groups, not so good. And for women of childbearing age and children, it's so far behind the second to last place nation that we won't catch up for a while. So keep that one in mind as we move forward. This one is even sadder. My youngest daughter is getting her PhD in clinical epidemiology at the University of North Carolina. And she sent me the results of this study. Now, this study is one that has only 3 points. You know, all the years are not in there. But this is maternal mortality in the United States. 26.4 per 100,000. And look at the rest of the industrialized world. Ours is 4 times the rest of the industrialized world. It's a national tragedy that most people don't know about and most people don't care about, quite frankly. Okay, now I just wanted to mention that for a moment. Altarum is the healthcare economist that we work with at COGME when we were at HHS. They're just pretty much scientists, and that's it. They don't have any axe to grind. The point of the matter on this slide is that we had a relatively stable percentage of primary care physicians in the United States among all physicians at 36% from 1978 to 2002. But in 2002, that percentage started dropping linearly, about half a percentage point per year, to the point that now we're at 29%. It's going to get lower because U.S. medical student interest in primary care has been steady at 14 to 18%, and that's shown on this slide. So the blue bars are the percentage of medical students in the U.S. who become general internists, general pediatricians, or family physicians. Starting in 1998, a dramatic decline through 2004, and then a leveling that has persisted until today. Now, that's U.S. medical graduates, MD grads. When you add osteopathic grads and international medical grads, that number actually goes up to 23%. So as we dwindle down, that's probably our bottom line. With that 29% could go to 23. Okay. So this slide is some real comparative data from the world and from all over the United States. These studies were done in several different places. Dartmouth Center for Clinical Investigation and some other areas, but the one that I like to mention is Barbara Starfield. Barbara Starfield was a pediatrician and public health specialist who headed up the Johns Hopkins and Bloomberg School of Public Health initiatives. They did their own research there, her team of researchers, but they also categorized the entire body of research in the industrialized nations in the world, and they determined what the characteristics of healthcare systems were that led to better outcomes and lower cost and better access. Now, I will say these were the industrialized nations, so in essence, the OECD nations. And so one thing that you don't see here is any mention of specialty physicians, because they were in good supply in those nations. But here it is. Number one, regional planning and resource allocation. That's not done in the United States. Actually, the ACA, the Affordable Care Act, authorized a National Healthcare Workforce Commission that never had any money appropriated for it, and even though it was named, it never met. So the attempt to do that didn't happen. Universal health insurance guaranteed by a publicly accountable body. Now, sometimes when I say that, people say that's socialized medicine. No, it's not. It just means that universal health care coverage and access is guaranteed in some way. Actually, the number of truly socialized systems in the world is relatively small. United Kingdom, Scandinavia, some of the Far Eastern countries, certainly Canada and Western Europe are not socialized, but they do have universal health care insurance. Number three, no out-of-pocket expenses for primary care services, and I should add, also for catastrophic events in healthcare. Again, what I mentioned to you was the reason people think healthcare costs are going up is because more is coming out of their pocket. It's exactly the wrong thing to do to curb healthcare costs, precisely. Narrower range of physician incomes, high supply of primary care physicians. This is important because of the other slide that I showed with the dwindling number. Starfield's work showed that nations that had the proper balance of primary care, usual sources of comprehensive longitudinal care, and consulting specialty physicians performed the best. And that ratio is, well, that number of primary care physicians is 40 to 45% of all physicians. Again, we're hitting right at 29% right now. Relationship with the usual source of comprehensive longitudinal care and a highly regulated insurance function. So many nations that have lots of private insurance also have it highly regulated, and more on that one later as well, which is right now. So do any of you know T.R. Reid, Tom Reid? Yeah, Tom Reid's a great guy. Any of you see him when he was here in Springfield last May? He was our graduation speaker, as a matter of fact. So in many of the things that I've done in my national positions in family medicine, Tom Reid has been one of them. He was a journalist for the Washington Post. He and two children have decided that they would travel the world and experience the world healthcare systems. He documented this in The Healing, which is a great book, and also in the PBS documentary Sick Around the World. If you haven't seen that, it's certainly worth seeing. Obviously, I'm giving credit to what the next slide is going to say, because I learned these things from Tom Reid first at the North American Primary Care Research Group, and then I was fortunate enough to spend 2 full days with him when he was here. Tom's idea is that we need to do comparative policy analysis, and we need to start at the highest level if we want to compete with the rest of the world in healthcare outcomes. So this is it in a nutshell. Tom Reid says that the United States has 4 different healthcare systems, and the other industrialized nations in the world all have picked one to have. And these are 4 examples. So one of our healthcare systems is the third world system. Before the ACA, that was 50 million people that were uninsured. It's now down, well, it was down below 29 million in 2016. It's now crept back, well, it was below 30 million. It's now crept back up above 30 million this year. But it still represents about 10% of the population that's uninsured. The definition of universal care universal healthcare access is 98% of the population. Near universal is 95%. So, you know, we're getting there. Obviously, that's an untenable system, no health insurance. Then the other three are the ones that Reed would say the United States should make a decision about which one that we want. Truly socialized medicine, the Medicare system, or our private insurance system. So I'll just make a couple of comments about those. Actually, my daughter Emily spent 5 years at the University of Calgary getting a degree there. And she was considered a Canadian settler because she was there for 5 years, which meant she had all the rights and privileges and paid taxes like a Canadian citizen. So she got her health card when she crossed the border, and she experienced it at every level: primary, secondary, mental health, and catastrophic health care. So as dad, you know, I got to experience it in that way. And also in my colleagues in family medicine in Canada, I came to know it pretty well. So I'm talking about three first. I kind of want I'll just continue talking about Canada. So the Canadian system is a system in which government assured insurance and a government payer works with private physicians, and almost always through an insurance intermediary. So it's like Medicaid managed care, or the Medicare managed care systems, you know, that we have. It was started in 1992. It was named Medicare too, 1 year before the United States. United States had Medicare. The Medicare system in Canada has been very successful in healthcare outcomes. It hasn't been very successful in attracting the number of physicians that are needed. They actually, you know, have a shortage of particularly primary care physicians, but 42% of their physicians, you know, are in primary care there. And there's a myth that physicians in Canada are not paid very much. The median income of Canadian family physicians and Canadian specialty physicians in U.S. purchasing power parity is higher than the income of United States physicians. So that's one myth. That one would work because we have Medicare now. Medicare is an efficient system. As I mentioned to you before, the outcomes compared to the rest of the world for our senior citizens are quite good. Now, the problem with Medicare now is the way that Medicare is funded, Medicare reimburses, is actually too low to sustain a higher system, and Medicare in the United States can shift costs to private insurers and to hospital systems. So we'd have to figure that one out. I'll go back to socialized medicine, like the United Kingdom. That's government-employed physicians with a single government payer. The physicians actually work for the government. The interesting caveat there is that that's true of specialty physicians in the United Kingdom, but not the family physicians. They are, you know, the GPs in England are really private, as a matter of fact. Again, their outcomes are good. They do have significant waits for secondary medical care. They actually have a science of wait times. They think about how much a person should wait based on their condition, which is better than just randomly being assigned to a queue to sit in. Actually, even though a single government payer and socialized medicine might be attractive to a lot of people, I think that one would be the one that would be hard for to get past Congress, for sure. And then the fourth one is an interesting one. It's the German system, and it's a private insurance system. Now, they have sickness funds, and those sickness funds are their insurance company. They're called Krankenkassen, yeah, Krankenkassen in Deutschland. And they've had their system for 135 years, so if you read Tom Reed's book, he'll call it the Bismarck system. And so in that system, the insurance companies are all not-for-profit, and they can have their medical loss ratio is regulated at about 0.90. The medical loss ratio in the United States is 0.66. Anybody know what a medical loss ratio is? Well, the medical loss ratio was a term that was coined by our insurance industry and called medical loss because, that's the amount they had to spend on health care. That's the money the insurance company lost because they spent it on health care, which means that they're making 35% on the bottom line. Medicare has about an 8% bottom line, the private insurance about 34%. And in Germany, it's highly regulated, so it's set at 10. The medical loss ratio is set at 0.9. In the ACA, there's a provision to have the medical loss ratio 0.85 for larger insurers and 0.88 for smaller ones. And it wasn't written in a very airtight way, and all kinds of loopholes were found, and follow-up legislation didn't occur. So anyway, in the United States, socialized medicine is the Indian Health Service, the military health system, and Veterans Affairs. So that's 22 million people. And then we have now 127 million people in Medicare and Medicaid. So that's a big system too. So we have some reasonable experience with all of these. And again, if the country ever had the will to save maybe $1 trillion a year and have better healthcare outcomes, we should pick one of these. Okay, now the last little segment here, I call the Dwight D. Eisenhower System of Interstate and Defense Highways. This again is stolen a little bit from T.R. Reid, as a matter of fact, because he promotes Dwight Eisenhower as the king of comparative policy analysis. So when Dwight Eisenhower, the five-star general, was elected president in 1952 and assumed office in 1953, he had come back from the European theater, and he had seen something in Germany pretty amazing. He saw the Autobahn, and he saw these big ribbons of highways going across the country that could move people rapidly and was great for communication and transportation. When he became president, he found that each of the 48 states had a plan to upgrade the U.S. highway system. And it was basically a two-lane system that was going to be repaved, still go through the main streets of town. And he, almost alone, thought that this would just not be the best thing to do. Excuse me. Anyway, he did some comparative policy analysis for some other roadways and promoted the interstate highway system and got it through. So the first work on the interstate highway system was started just west of St. Charles, Missouri on Interstate 70, right? And Interstate 270 in St. Louis was the first interstate highway with 3 digits, so that worked. Now, just another word about comparison. I think we need to put our egos aside when we take a look at these healthcare systems in other countries. This is my obstetrics textbook that I used in 1981. And it was the authority for medical students and resident physicians, and I wound up delivering 1,900 babies, so I really liked it. You can kind of see the coffee stain right there. That was somebody else's. But this is a pretty cool book because there was 1,102 pages in the book, and those long nights when women are in labor, sometimes we just read the index, right? Well, here's a pretty good index. Chauvinism, male, voluminous amounts, pages 1 through 1102. That's real. But what does that say about comparative analysis? Well, the first step is actually realizing that you've got a problem. Now, it took several editions for Williams to kind of get out of that chauvinistic role, but they eventually did. So that realization was the first step. But you might ask yourself, what really is happening here? Why can't we step back and look at the good things that other countries are doing and save that $500 billion to $1 trillion a year and actually make people healthier? Well, it's the dilemma of authoritative knowledge. I'm going to go back to Honduras for a second here. So there we are in the back of a truck. That's Ann Fielmeyer, the blonde whose head is turned away. She was a midwife student at that time. And as we rode back and we're bumping along, she said, Jerry, you should read a book, Birth in Four Cultures by Bridget Jordan. It's a great book. It compares birth in 4 different places, but in the middle is like a PhD thesis where she talks about important things like authoritative knowledge and ways of knowing. So for any particular domain, several systems of knowledge exist, some of which by consensus come to carry more weight than others because either or both of structural superiority, the bottom one, they're a stronger power base, or they explain the world better, efficacy, or they have better scientific outcomes. So that is true about how power systems develop. The unfortunate thing is when one becomes very powerful, to legitimize one way of knowing as authoritative, adherents devalue and often totally dismiss all other ways of knowing. Those who espouse other systems are seen as backward, ignorant, or naive troublemakers. We've got a fair amount of that going on in this country right now, and somehow we have to figure out how to get out of it. Okay, so now my analysis, okay? And I've given you some examples that have gotten to this point. Number one, if we can do it, pick one healthcare system instead of 4. The second one, we have to have a higher supply of primary care to get this done if we're going to do it efficiently. One, and the one that's emerging and is a little bit closer to home always, are the various kinds of care coordination. So having registries of patients, knowing where all of the patients are, seeking those out who need care, and breaking down the barriers to care is going to take us a long way. It used to be in medical school that we teach, and we still do, that just take the best care you can of everybody who comes across your doorstep. We certainly want to do that, but it's not good enough because we really need to have the registries and regional planning to find all of those in need. The second one is focus on high-risk, highly vulnerable, and high-cost patients. Our project. I'll just tell you, the power of this is incredible. So in Enos Park, we did hotspotting, and we found the people that had the top 1% of costs. Each one of those had healthcare costs per year of over $100,000. The cost after 2 years for that group was cut by more than 50%, some of them by 90%. Amazing. And our medical students were in there, getting that hot spotting done. The second group, the top 10%, generally cost the system about $30,000. And a simple 2-visit evaluative visit by a nurse and a referral to a doctor's office over a 2-year period of time cut $12,000 a year off their cost. That's a lot. 400 patients means $4.8 million a year. And that's the number that Memorial Medical Center did, as a matter of fact. The rest, the other 90%, just with a system of being found and offered care, those who received or actually had signed up for a year for care versus those who, the year they didn't have insurance, cost the system $2,000 a year less. So it's very, very easy to do. Okay, the focus on high-risk, highly vulnerable patients is best done with community health workers and the nurse intervention, and then I'll just skip that one. So actually, that slide I'm not going to talk about, but I just want to say that I'll stop here, and I think we've got time for a few questions tonight. But the issue of learning from others and putting systems together is an important one, and there's an astounding amount of data. And most of these effective changes start with people on the ground. So we've got some ways to participate at SIU. So if any of you are interested, you can let me know. Anyway, thanks for your attention tonight, and I'll be happy to entertain any questions you might have.